Thank you.
What I would do in the next 15 minutes is purely a clinician's perspective, and I would take you through some of the challenges of the trials, especially the phase 1 and the phase 2, how the extrapolation could be done from the traditional model of the cytotoxics, and also draw some examples from the literature. It's well said that one of the features which is thought to distinguish man from other animals is his desire to take medicines. And every era, every period in history has had its own. We know that many natural substances contain bioactive plants around us, and thank you, sir. And the discovery of novel drugs which have led to major leaps, especially in cancer therapy, has been from the botanicals. And about 50% of the drugs approved in the time period from 1980 onwards, they were natural products or derived from them. And in the 20 years, in these 20 years, a lot of drugs like the camptothecins, taxanes, and the newer version of the vinca alkaloids, they were seen by the oncologists, and which were a leap forward in the management of various cancers. In the short period between 2000 and 2006, 26 plant-based drugs were approved, and we would continue to see evolution of these drugs, and probably there would be multi-component botanical therapeutics which would come up in the days to come. At least about a quarter of the drugs are directly derived from plants, and another quarter are chemically altered natural products. 50% of them are something to do with plants. But imagine this is just about 5 to 15% of the 250,000 higher plants which have ever been actually investigated for any bioactive compounds. So there is still a lot to go and a lot of ground still to cover. And we know that an ideal drug from an oncologist's perspective would be the one which would give a good anti-tumor activity and minimal toxicity, but that is something hard to achieve. No doubt our understanding of the biology of cancer and our experience from the drugs we have used in the past is leading us to better therapeutics. There are two ways plants could be used by clinicians, by oncologists. Supplements, for example, some immune boosters, emulation of the morbidity. Dr. Kataria has already very elegantly shown some of them, and they could be directly anti-cancer. And this is what an oncologist loves. This is his like a home page when you talk of the botanicals. And look at the path-breaking drugs, vinca alkaloids. And I can share one of my experiences from a hospital abroad who shared that the best vincristine comes from India, none other source. All other vincristines lead to peripheral neuropathy very soon. We know that about a cumulative dose of 20 milligrams is something which is required to induce peripheral neuropathy. But this particular very large cancer center in the US was at one point accessing vincristine from Australia. And the onset of neuropathy happened at 6 milligrams per meter square. Now that was something amazing. And come to topo inhibitors, the typical drugs, the topotecan and the other camptothecins, irinotecan, and one of the most celebrated drugs are the taxanes and Taxol, which is one of the drugs which has been the workhorse for the treatment of breast, lung, ovarian, stomach, name a cancer and it works there. Head and neck, across spectrum of histologies, both adenocarcinomas, squamous cell carcinomas, and both the drugs, paclitaxel as well as docetaxel, are very strong out there. Use of complementary and alternative medicines has been prevalent for very long, and it is increased from 34% in the 1990s to 42% in a short span of about 5 years. And the total the expenditure was a staggering $27 billion in the US. And this ranges from 30 to 75%, and some of the products I have listed out here. Shark cartilage, especially from the white shark, that was something which has been very intriguing. People thought that the white shark never gets cancer, and therefore there might be some property in the shark cartilage. And the powder was once upon a time commercially available in India as well, and I learned that this is still prevalent in the Western world. Now, surprisingly, the use of the alternative products has been very prevalent in the pediatric population, almost up to 80-85%, more than the adults. Now, there are two operative definitions: alternative therapies and complementary medicines. The complementary medicines are actually the use of unconventional treatment modalities and approaches that are non-surgical, non-pharmaceuticals. And once they are combined with the mainstream care, these modalities can actually enhance the effectiveness and reduce adverse symptoms. The alternative therapies are not scientifically validated. Now, this slide shows the cumulative use of the alternative medicines and the non-disclosure by the users. Now, this is very high, and this is disturbing in our clinics also. We don't have a systematic survey, but we estimate that about 50% of our patients are also on some sort of an alternative therapy, and they are not divulging to their physicians. At times when we land into unexpected toxicities, that's the time when the questioning goes in, and we do get to know that somebody is on some pudia or something, a powder which the individual is even not aware of, the constituents are not aware of. And now, what are the challenges for the clinicians, the researchers? That these are the most of the botanicals have not been amenable to controlled clinical trials, and there is an inconsistency of the botanical herbal product, the batch-to-batch variability, and unknown unwanted biological effects. There could be organ toxicities, GI upsets, rare renal hepatic injuries, and even drug interactions. And there is a lack of adequate preclinical models. There could be an interaction with the stromal and the immune cells we are not aware of. There are concerns about the herb nutrient drug interaction and product quality standardization, and therefore this concern led to the creation of the National Cancer for Complementary and Alternative Medicine in the US. And this is not long back, this is just about 15 years back. And what was the outcome of this activity? The outcome was that most of the prevalent the herbs and the supplements, they were actually tested both in the preclinical phase 2, phase 1, phase 2 and phase 3. And these are the trials which happened in most of the university hospitals across US. And just to give you an example of green tea, nobody would actually believe that green tea could be bad for any cancer patient. One of the anti-cancer drugs, bortezomib, which is used for the treatment of multiple myeloma, once this was introduced in Southeast Asia, where the consumption of green tea is almost rampant, everybody would take, the effectiveness of bortezomib was thought to be lower than what was reported from literature. And then this was discovered that patients who were on green tea had lower levels of bortezomib. So in the clinic, we would routinely advise our patients who are on bortezomib not to go for consumption of green tea. So these are very small little examples where an individual could be on one of the supposedly harmless, innocuous product, and one could be actually doing harm. I would show you one of the examples in the next slides. So, not to take you through all these, probably you understand them better than us. There were phase 1, phase 2 trials on most of these products, and shark cartilage, in fact, there were 2 phase 3 trials, and not much came out of this. And the famous nutritional regimen of Gonzalez was actually tried in a randomized trial of pancreatic cancers. Again, this is a highly individualized the dietary supplements which are given to these patients. Now, let me take you back to the typical phase 1 setting in a cytotoxic trial. What happens? Because the drug has never been used in humans, it's relatively toxic, so you don't have volunteers, you have only patients. And there are no important practical constraints on the dose. And the dose response curve is monotonic, I would show you. And the dose response and the toxicity curves are very close to each other. And therefore, you start with a low dose, build up in cohorts, and that's how you proceed. And there could be, apart from only finding the doses, there could be many more actually outcomes which could be part of the phase 1 trial, like this could be a biomarker driven, this could be a ex vivo assays, or there could be even a tumor response in some of the trial designs. But what happens when we extrapolate these typical cytotoxic trials to traditional botanical drugs? Is it possible? The argument is that there is history of human use, no need for a phase 1 trial. And also the argument is that a trial, phase 1 is typically to be done on humans where it has never been used. And some of these botanicals are in use for centuries. Why do you need a phase 1 trial? And these drugs are known to be safe because they have been in use for very long. And also that these trials probably may not be possible because the maximum tolerated dose is irrelevant for botanicals because they have low toxicity. But what about the safety? There is a complex medical history for a cancer patient, and there are concurrent treatments a patient may be on. One fine example is the St. John's wort and chemotherapy. This is known to reduce the blood levels of irinotecan. If your patient of colorectal cancer takes concurrently St. John's wort, there would be lower effect and a poor outcome for this patient. So a very innocent supplement could harm the patient. Some of the immunostimulants are bad if you're using monoclonal antibodies because there might be an endogenous immune response against the antibody and you could lower the final outcome. And of course, the dosing in cancer patients, the other additional benefit would be, you just can't believe the practitioners and the manufacturers. It's not a trial or a dermatology trial where one could look at the lesion. In 2 weeks' time, you get the answer. Is it regressing or not? Cancer is a very complex. Either you win the game or you lose the game. There is nothing in between. Either the cancer wins or you win. It's unlike a dermatology practice. Now, first, the toxicity tends to be lower. We know that. And there may be no serious adverse event, actually. And take the example of a mushroom. The individual might continue to escalate the dose. There may be no SAE. And there could be a phase 1 trial which would never end, actually. And the second drawback is that the dose of chemotherapy, you could hike it by even 100-fold. And if the toxicity doesn't go up, it could still be infused from the same dextrose or the saline bag. But if the dose of a botanical has to go 100-fold, an individual might be consuming 300 capsules in a day or a large amount of concoction in a day. Is that possible? So, which would not be possible from a standpoint. Now, I mentioned about the dose response and the toxicity curve. What did I mean? This is a typical dose response curve. The first curve is the one which shows that this is the dose response and this is the toxicity. Now, in a typical phase 1 trial, about a 33% toxicity would be taken as a maximum tolerated dose. 1 in 3 patients getting an MTD would be enough. Now, if you, for any reason, drop the dose, say from 30 to come down to 20, there is a sharp drop in the outcome of this patient. And therefore, on the other hand, if the dose response and the toxicity curve are too wide apart, now which might happen for a botanical. So therefore, you just don't know where to put the dose. And on the contrary, there could be a botanical which is absolutely not toxic, and you keep on escalating the dose. This is where you get the MTD, and you already have run through the best response. So you might pick up a dose which is something beyond the maximum at which you get the best response in that particular tumor. So these are the practical difficulties, but at the same time, there may be interactions, and these interactions with the conventional agents, and I have already talked about the irinotecan. Andrew Vickers from Memorial has proposed, I'm sorry for this slide, this is, but still I could go through this. He's proposed that if you are actually combining a botanical with a chemotherapy agent, how could it be done? You give the after the consent and the run-in period, you do the chemo infusion on day 7, give a gap of 10 days, start the botanical. And you could go to another chemo infusion on day 14. So what you are doing is you are bringing the botanical in between, You have seen the drug off for the 3 days, you have seen the botanical for 4 days, and you are bringing in the chemotherapy again, and then there is a mandatory waiting period of 7 days to complete a 3-weekly cycle for a typical cytotoxic. And this could be a good proposal for doing a phase 1 trial for a botanical chemotherapy combo. I think with that, I would make some conclusions that there are more anti-cancer botanical agents than could possibly be put into clinical trials. I've shown you the number of products which are available, and there are major challenges in choosing which one to take forward into early phase studies. And patients or practitioner opinion is of little value. We have to depend heavily on laboratory studies. It just cannot happen because something is written in the literature. And the initial lab studies are essential to study the safety, and then only this can move. We are not interested in studying an anti-cancer botanical because we want to find out more about it. We want to create a drug out of it. Now that's the crux of the whole exercise, and we are finding that if we can help our patients live longer, healthier lives, I think the job would be done. And let us imagine that our work leads to something which is a single treatment that becomes routinely used for cancer. And therefore, we have to focus our energies on bringing out that one particular treatment, like the story of Taxol, like the story of docetaxel or Winker alkaloids, or even the other vincristines. At the turn of the 20th century, about half of the entries in the US pharmacopoeia were based on plants. No surprise. But they were discarded not because they were harmful or ineffective, but they were too complex to study. Now this is historical, and now the gap between the conventional and the alternative practices has diminished. The mutual mistrust has diminished. I think it is time for us to move on and reevaluate the possibilities of botanical medicine. So this is the time, because the technologies have matured. All of us have understood our own areas, more than the stronger areas, the weaker areas. We understand that the responses in cancer, the outcomes in cancer have almost plateaued off. We need more drugs, better drugs, smarter drugs, and probably plants are the best friends around. Thank you very much for your patience.
Thank you very much, Dr. Vaid. You really put it nicely.
Prevention, or if, say, if I have a family history, but I've never, but my parents have had or there's been cancer in the family, then is there a growing habit in the Indian consumers to use botanicals for prevention?
I will answer your question in 2 parts. A, we are all disturbed because of the increasing incidence of cancer, more cases. In 1931, there was a survey, the only survey, health survey conducted by the British in India is 1931. Cancer was not one amongst the top 10 diseases. So what has happened between 1931 and 2011? In the 80 years, something explosive has happened. We could blame it diet, our lifestyles, environment, and everything. And what was it before 1931 which was protecting us from cancers? And there is a very unique publication which happens from Japan every couple of years. This is a health survey the Japanese government actually publishes, and they have the health records, the birth and death records of every Japanese national from 1895 onwards. Now, what they have done is, this was a publication about 15 years back. They studied 2 periods, pre-1945, the World War II and the post-World War II, when the industrialization change in the food habits happened. Japanese society was, pre-World War II, was no milk, no meat society. And that is the big change which happened. And they've shown, beautiful curves they have shown, how the incidence of ovarian, breast and everything, and per capita consumption of protein, eggs, everything is mapped out. So there is something with that. Something is happening. So we are leaving our traditional diet. And there comes the role of protectants like curcumin and so on and so forth. So that's probably one part of the answer. Our traditional Indian diet, call it vegetarianism or closer to nature or less processed foods, whatever it is. Now, second part of the way I would answer your question is that there is now work which is actually on, and I recently had the opportunity to listen to one of the speakers, an Indian who's working in the US on prevention of breast cancer by Ashok. In fact, my eyes literally, I stood up when I saw that presentation. So, I think how we are living is leading to all that is happening, and because we were using less processed foods, and there is work now. So to scientifically answer, yes, the work is already started. We have started looking at plants as prevention of cancer in a more systematic manner.
So, but what do you see in an Indian environment? Do you see a growing consumer habit in India, in your clinical practice, maybe, or in the other doctors' practice?
I think Dr. Talia would like to answer.
Well, I think the answer to your question is partially yes. We do see patients when we inquire, they are using tulsi, they are using rejuvenas, they are using so many other complementary foods, which we were not using traditionally. They have started adding them on once the diagnosis of cancer has come in, or once they are started on treatment, either with chemotherapy or radiation, or they've had surgery. And we have to go back and inquire from them, because as Dr. Vaid elegantly pointed out, that these are antioxidants and they reduce the effect of the tumor cell kill. I, as a practitioner for the last 25 years in radiation oncology, talk to my patients and tell them, please do not take any antioxidants during therapy. Because I showed you in the double-strand DNA break, it is the nascent oxygen, which is a free radical, which is the oxidant that's going to denature the double-strand break of the tumor. So similarly for chemotherapy, we do not yet understand what is it that is preventing the tumor from going away once we add on the cytotoxic or the radiation. But the patients are using, and we do not have a study to quantitate how much, what drug, what botanicals, and in what form. But yes, the patients are using.
After the therapy is over, you are encouraging them to...
Yes, after that we do to prevent the side effects.
But sometimes they are unnecessarily spending a lot of money actually. They want to spend more on the other stuff rather than the mainstream.
If I can just add what you pointed, I think it's 2 years ago, there was a major landmark study published. There are 4 clinicians from Europe and America collaborated with epidemiologists, and this is a very landmark study. They linked the occurrence of cancer to the local food. So all over the globe, they looked at the type of food people consume, and then linked with what type of cancers are occurring. So I think this study shows the way in terms of what you are alluding to earlier. This was, I think, published 2 years ago by British. This was done NIH and British health system together with close to 400 claims and very, very big studies available, I think, free on the net.
I'd like to add here, that selenium, which is a very potent antioxidant, it has been shown to reduce the effect of mucositis and radiation-induced fibrosis in the concentrations of about 400 micrograms per day. When I came across this study about 10 years ago, I've added it on for post-therapy supplement to the patients. So we give them multivitamins, but I always look for the constraint of selenium, and we're getting about 100 micrograms per day per capsule. So we have to administer about 3 to 4 capsules to these patients. And believe me that these patients have had a healthy recovery, and also their fibrosis, especially subcutaneous fibrosis in the submental areas where we treat the head and neck, has started going down.
Yeah.
I think it is wonderful to study from scientific point of view the pure molecules equipment, but there are hundreds of questions on viability of equipment. And cyclodextrin complex is now coming. But my point is that if we are going on experimentation of pure molecules, it should validate the claim of turmeric, not curcumin. So turmeric, because of polysaccharide which is present in turmeric, that assists in the bioavailability of curcumin. Therefore, when it comes to the treatment, it should be holistic treatment. When it comes to the investigation, validation, it can make it with the pure compound.
Yeah, I alluded to that thing in a moment earlier on. And just to summarize what the discussion was going on, is life instead of becoming easier, it's becoming more complicated. As you said, it's not about botanical, Ayurvedic medicine, the food, nutraceutical supplements, the juices, the drinks, and people are consuming diabetes, not only cancer, is increasing in India. We used to have gulab jamun, now we have Pepsi with it. And so certainly diet has something to do with it, but it's coming from all the angles. But we have to be open-minded to look all the aspects. That's one of the problems of this area, that we have to be very comprehensive in all sides. What they're eating, what they're consuming, what botanicals they're taking. So it's really make things a lot difficult in single drug. With that one, I will ask somebody who knows the both sides of the world. So the next speaker is Geeta, who is does not need any introduction. Dr. Krishnan is involved in Ayurvedic and also in clinical. So, and he is one of the active person that I know in this area that trying to bring both sides together.